Well, good morning again, everyone. And I am just delighted to introduce this morning's keynote speakers on the topic Keys to Advancing Care, Equity, and Harm Reduction. We have from the California Bridge program, who is involved here in California Bridge? Yeah, excellent, excellent. If you don't know, California Bridge has been an amazing resource in California in being that door where people can come in, start treatment, and then find their place in the community to continue care. California Bridge is doing wonderful work around equity as well, and that's our topic today, where we're going to be hearing from Charles Hawthorne, who is the who does the equity and harm reduction work as the capacity building manager. And he will also introduce himself. And then Josh Luftig is also a founding member of California Bridge and another wonderful resource in our community. So hope you all enjoy this. I know you will enjoy this session, and please warmly welcome our speakers.
Thanks, y'all. Cool, awesome, it's so nice to be here. So yeah, I guess I can go ahead and just flip through these slides real quick. We were talking a little bit about keys to advancing care, equity, and harm reduction. We don't have any disclosures. We are not connected with any specific companies or any specific things. We might say some brand names at some points because we are all human and slip up, but in general, we'll try and stick to the drug name as much as we can. And then September is National Recovery Month. And so it's really important for us to all be having these conversations and thinking a lot about what it can look like for people to transform their relationships to substances, transform their relationships to their communities and their contexts that influence their relationships to substances. And yeah, we want to make sure that we're also talking about making sure it's accessible to everybody. And that's what this is really about. So yeah, just to go ahead and start off, my name is Charles Hawthorne. I'm the Equity and Harm Reduction Project Manager at California Bridge. I've been at Bridge a little bit less than a year now. Prior to that, I was at the National Harm Reduction Coalition, where I was supporting harm reduction programs, syringe service programs across the state, in helping to improve their infrastructure, improve their work that they're doing with people who use drugs, doing a lot of coaching and support with that. And now I do a really similar thing, but with all of our emergency departments across the state. Yeah, I have my master's in public health from Johns Hopkins. I was a Bloomberg American Health Initiative Fellow in the addiction and overdose cohort. And so I've been working with teams there for a while and just kind of bringing all of my worlds together and talking about equity and harm reduction and access to care and rights for people who use drugs and all those things that are really interconnected to each other. And then I'll turn it over to Josh, and he'll go ahead and take the first portion of this.
Hi, thank you so much for having us. And it's really exciting to be here with so many people who are passionate about addiction and treatment. I'm Josh Luftig. I'm a PA. I'm in the front lines in the emergency department in Oakland, California at Highland Hospital. I've been a practicing clinician for 20 years. And I'm one of the founding members of California Bridge, which has been a privilege to be a part of from its inception. I'm also the director of harm reduction services. So if you've ever come across the various toolkits, and particularly the naloxone distribution toolkit, you can blame me for lots of portions of that. So first off, let's move to, okay. So California Bridge, what is California Bridge? We have a simple but ambitious goal for 24 access to high quality treatment of substance use disorders in all California hospitals by 2025. And how are we going to get there? So first of all, we've seen, oh good, the animation's working. So we've seen it grow from 6 hospitals that included urban and rural hospitals, and going to 6 to 12 to 30 to 50 to 100 to 200, and now we've passed the 200 mark and we're headed towards 300 hospitals. So this, very exciting. Yeah, tremendously exciting to see that growth. And it really speaks to the appeal of this movement, that it's not just a couple people saying what needs to be done. This is many, many people who are finding this to be a solution to a problem that faces our state. So how are we going to get there? How are we going to get to universal access to high quality addiction treatment in a 24/7 on-demand way? Part of this goes to establishing a brave space for dialogue. And I have a quote here, which is, learning necessarily involves not merely risk, but the pain of giving up a former condition in favor of a new way of seeing things. So we have a diagram that shows the comfort zone, the learning edge, and the unsafe zone. And there's conflict in that learning edge. And I like to think of this in two ways. One is as a person, as an individual, an internal dialogue that you have with yourself as you move from one view of the world to another view of the world. And it can be sort of, there's a conflict and discomfort as you go through that process. And then one way to look at this is the external, as you bring institutions and other people that you're engaging with on that same journey, and they're going from their comfort zone towards an unsafe zone. And that's a lot of what we're doing. That's what the transition is across healthcare in California right now in regards to addiction. And an example I have was after practicing emergency medicine for many years, when I first encountered the idea of bringing addiction treatment to emergency medicine, I had a negative reaction. The idea of bringing, it didn't feel comfortable. It felt outside of my understanding, felt like something that someone else somewhere else should be doing in a methadone clinic. Didn't feel like the ER was the right place. We didn't know how to manage those patients. We didn't know about buprenorphine. We didn't know any of the treatments. All those things elicited a fear response in me because I was encountering that discomfort. And as I went through it and grew and learned more about buprenorphine and how we can incorporate this into emergency medicine, I started to expand my comfort zone. And then I get the privilege of coming to hospitals and clinicians and nurses and techs everywhere who have who are kind of still at step one, and help walk them through that process, because I've been right there. Like, I completely understand the discomfort with it and what that's like. But that's how we grow. The bridge model has three elements. One is low barrier treatment. So we don't want treatment to be this far off thing that you have to go through step one, step two, step three, and wait a bunch of time and have your right insurance and make these appointments. And that's a setup for the people who are highest risk, who are having chaotic drug use, to never get to that step. And they're the people that we most want to get to that step. So we have to bring addiction treatment right to wherever they're at, whatever door they enter. And often that door is the emergency department. The more chaotic your drug use is, it's like gravity. You fall into the emergency department. That's a common pathway for many people who have the most severe and they're the highest risk. And we want to have addiction treatment right there without any barriers. Connection to care and community. So that's the substance use navigators who are linking. They're a human connection, an advocate who is closely engaging that person and then connecting them tightly with follow-up care, with the entire community of support that's going to be there for them to catch them. So that the safety net of the ER is bridged to the safety net of addiction treatment resources. And there's a human being who's there, who's advocating for them, coaching them, and supporting them in that transition. And a culture of harm reduction. So that's changing the entire, turning the battleship of attitudes and beliefs and practice patterns of institutions that generally start out very stigmatizing and hostile to people who have substance use disorder, and changing that narrative around. And part of there's many strategies to doing that. Part of that is having a substance use navigator who is modeling proper language and behavior and engaging and support and being a human embodiment of the program. And then the champions who are trained by California Bridge and are on board, and the nurses and everyone who's kind of getting, changing the way they talk and think about substance use disorder and transmitting the message, and having signage up in the waiting room that says we have, free naloxone here, all these, and then having naloxone that you pass out, like those acts and everything that you do related to that helps change. All those small acts added together equal culture. And that's how that starts to change. The harm reduction approach. So harm reduction utilizes a spectrum of strategies to reduce the negative consequences associated with drug use, sex work, and other behaviors. And there's multiple elements of that, meaning there's safer techniques, managed use, and abstinence. And the general idea that unites these is that you are meeting people where they're at, wherever they're at. So the traditional model of healthcare, sort of the conventional approach, is that it's abstinence or nothing, like my way or the highway. Like the moment someone is not abstinent, there's a disengagement. Healthcare is like, we're not responsible. You're on your own. We don't care for you. And that's how you get these overdose fatality rates that are through the roof, this disengagement. And so the goal here is to change that entire model into, where are you at? Let's do a patient-centered approach and meet people right where they're at. What are you ready for? And let me offer everything I can to keep you safe where you're at. And through that engagement, we start to move the conversation to a much safer place. And we create, rather than disengagement, we're fully engaging people who are very high risk. How does practicing harm reduction advance substance use treatment? So I think the best way to illustrate this is to describe a very common situation. So I'll be working in the ER, and someone will come up to me and they'll say, this patient isn't ready. They're not interested in treatment or anything. They're ready to, in fact, they're like halfway out the door. And like, okay. So first of all, one thing is salience. So salience is how immediate something is, how much you perceive about a situation, and how nervous it makes you feel. If something's salient, it's right in front of you, and it just is like alarm bells are going off. So right now, my heart rate is like going way high. I am very nervous about this situation because I have a patient who's the system is kind of trying to disengage. We're kind of like falling into this old pattern of disengagement. Not interested. Okay, bye, goodbye. And I'm going, okay, here's someone with potentially chaotic drug use who's about to leave and has an incredibly high risk of overdose and HIV and Hep C. And because of all this work with addiction, I feel that intensity as if someone is like bleeding in front of me. All the other things in the ER that make me nervous are now being nervous. And whereas generally in the past, I would have been asleep at the wheel and been like, okay, fine, like next patient. And because of the education and understanding that I have, I feel the salience of the moment. And so how I will approach that situation now is go in and engage that person. What's going on? Like, you came in, first of all, thank you for coming in and having this abscess treated like that. I know it's really scary. It's like, abscess drainage can be incredibly painful, and you're used to being abused by the system. And, so thank you for coming in. I'm so glad you came in. That was really brave. And what can I get you? Are you hungry, or you look uncomfortable? Are you in withdrawal right now? What's, where are you at? And have you ever overdosed in the past? Well, first of all, let me back up. Can we just, is it okay if we talk about drug use after I've met their immediate needs of food? Do they need shelter? Do they need transportation? Like, starting to marshal all these resources. The hospital and the ER have a tremendous amount of resources at their disposal if we tap into them, if we recognize an emergent situation, which is recognized. So recognizing is a first step. So I have recognized viscerally now, like I'm recognizing this is an emergency. And so I'm starting to pull in social work. I'm reaching for my substance use navigator to come in and help me engage this patient, because I recognize that engaging this patient is our best chance to make this person as safe as possible in this very high risk situation. So I want to know what needs are not being met right now. Do they not feel safe? Like what's going on? Do you need a medication to help you relax a little bit? I got that. I've got a social worker who will help you with shelter. And so you start to build in all these little pieces are starting to add together so that the person on the other end recognizes that you are going to bat for them in any possible way. You don't have an agenda of like buprenorphine or you're out of here. Like, it's like, no. You're just trying to understand where this person's coming from, get in their corner and troubleshoot everything you can. And through doing all these steps, and talking about the risk of overdose, once you kind of made it to that part of the conversation, and being like, I have fentanyl test strips. Do you have Narcan? Have you ever overdosed or seen anyone overdose? Do you know about fentanyl? You know, it's getting into everything. And I'm just really worried about you. I want you to be safe. I want you to have a strategy, have a plan. Think about safer use strategies, clean syringes, you know, smoking. Maybe you can transition to smoking instead of injecting. We have pipes if you need, you know, like, all these things. And usually patients are pretty floored by having a healthcare provider getting right in there in the mix with them and having any kind of understanding of what life is actually like and what the risks are actually being faced in that moment, and helping troubleshoot their insurance. Do you have insurance? I can help you. We'll get financial in here to help you fix it. Like, you know, being able to just pull in all these resources for this person is recognized by the patient. And then by the time you actually get to a treatment question, hey, I can help you, make you feel better. And let me tell you a little bit about buprenorphine that many people don't know. The reason people like it is it does three things. It protects you against overdose, it treats withdrawal, and it treats craving. And those are things that people with addiction really think about a lot every day. And I understand if you're not feeling it right now, or maybe you're not even in withdrawal, you're not ready to start right now, that's fine. I can write you a prescription, and that prescription, what pharmacy is good for you? I'll put it to the CVS that's near you or whatever, or a hospital pharmacy, and that prescription is valid for 6 months. So even if you're not ready in this moment, here's a home start instruction sheet. So you can start at home and have whenever you want, maybe in a week, maybe in a month, you're ready. You change your mind. I want you to have this prescription available to you whenever you decide, because it's a life-saving medication, and here's why. And I just explain it, and it's actually not that hard to turn that situation completely around. And often patients are actually ready to start buprenorphine right there. They went from halfway out the door with everyone kind of like relieved that this person is leaving, to now this patient is actually engaged in healthcare, sees the healthcare system as a place that has meaningful interventions and support, rather than a place that is just hostile and not helpful at all. Charles?
My mic on? There we go. And I just to kind of like add a little bit onto this, like I just really want to shout out Josh and the whole team at Highland, because Highland is like, yeah. If any of y'all are ever up in Oakland and like have like some time to do like a tour of the Highland Bridge Clinic, it blew my mind. It is really wild to see the way that y'all have like set up this program, because really what it falls down to is it's about power. It's about, as providers, as healthcare providers, are we more invested in holding purse strings and holding the reins and holding the power of who has access to what and when and how and under whose rules? Or are we interested in giving the people who are coming to access services from us the tools and resources they need to make their own informed decision about their own life in order to maintain their own health? And I really love that, because I think that that's a lot of times what harm reduction has done and changing the culture of how people are starting to do this work at Highland and at lots of other hospitals around the state as well. So I guess now we can go ahead and keep on pushing. So the other side of this that we kind of talked about is around racial equity. And so for me, this is a little bit of my North Star when I moved into this ED work, which is the statistic that Black patients are 77% less likely to receive buprenorphine in the outpatient setting than white patients. And this feels really big to me for a few different reasons. I think in my own work, I do in like my own personal praxis and my own personal politics. There's a lot of things that I think about in terms of like, how are we starting to change and break down the system? What is our system even going to look like 10 years from now? What are the things that need to be reformed? What are the things that need to be destroyed? What are the things that need to change? And I think through all of that, what I understand is we're still going to need an emergency department. We're still going to need a place for people who are experiencing medical emergencies to be screened, seen, treated, and stabilized, and referred to ongoing care, which is the function of the ED. And so when you are in that space, I think that it really puts us back like this in perspective. And so even this whole summer, we were doing all of these trainings with hospitals who were coming on board to bridge for the first time. And this was a statistic that we put up and we talked about it. And it made people, I think that it put things in a different perspective for folks, because it's like, this is something that the ED can change. People, the emergency department is the only healthcare service in our country that you are going to be treated. You should be being treated and seen regardless of your ability to pay, regardless of your insurance status, regardless of your race, regardless of your gender, regardless of your religion, all of those things. The emergency department has a legal obligation to see everybody, which means all of these patients that are often being missed in the outpatient setting are coming to the ED. They are showing up. The research shows that people who use drugs utilize the ED oftentimes as their primary healthcare service. People who are low income use the emergency department as a primary healthcare service. And so we have an opportunity to start to interrupt these things that have emerged from our larger healthcare system and give people a chance to kind of lean into it. And so what this has pushed me to start thinking about is, now that we see that there is the capacity, there's a responsibility and an obligation to do it, and there's an opportunity to really shift the experiences that patients of color and Black patients specifically in this stat, but all patients have in coming into the ED and coming into substance use treatment as an entire care system. How are we starting to flip our head on that and really starting to ensure that everybody coming in is getting the care they need? And so we, as the California Bridge program, when I came on, along with our director of equity, Kara Tolles, who was an emergency department physician at UC Davis, we started thinking about that, and we kind of went back to the beginning and started building out kind of these concepts of what racial equity meant to us and how racial equity looked like. And so with some of them, and sometimes you read quotes like this, and it kind of snaps everything into perspective. And so this quote, which is from the Aspen Institute, says, "In a racially equitable society, the distribution of society's benefits and burdens would not be skewed by race. This would be a reality in which a person is no more or less likely to experience society's benefits or burdens just because of the color of their skin." And I think that we can kind of break that down. Race is a very complicated thing, and nationalities and the ways and that people have journeyed to America and all the different experiences that people have had for generations and generations. So color of skin doesn't necessarily always capture it. But what it does say is, when I walk into an emergency department, I am a Black person. And I know that there are people, I'm from, Oakland is Oakland, Highland is a very special place. I'm from Indiana. And I get treated differently depending on where I go. I went to school at Purdue, which is, for folks who don't know, the middle of nowhere. And there are 3 chapters of the KKK within a 20-minute drive of my undergraduate institution. That changes the way you engage with people in those communities. It does. And so, I think that there's ways that you can engage with it where you put the blinders on, where you pretend you don't see it, where we don't talk about it, where we don't name it, where we dance around it, or you can dive in and you can say, and you can ask these critical questions that quotes like this said for us, which is, are the benefits of our service equally available to people based on, regardless of their race, regardless of their background? And once you start digging into that, that's when all the skills start kicking in. That's when who here is a data person? Okay, we got a few data people. How comfortable do you feel doing demographic data? 1 to 5, okay, we got a little handshakes a little bit. Yeah, those are big things. And I think that sometimes we don't always build out those systems because we don't always know how to do it. We don't always see, one of my favorite things that data people always pose is if we're not gonna use it, don't ask it. If we're not going to use it, don't question it. And I love that. And it also gives us a space to think about, how would we use this? Or how could we apply this knowledge that we're getting? If you're seeing that like there's a correlation between race and income status or race and insurance status, and you're seeing that there's a disparity in access based on those things, that's a way to kind of talk about race. And so kind of to also start to pull this forward and bring it together, I think it's important to also recognize, how did we get here? How did we get to a place where we are sitting in this conference room talking about advancing substance use treatment? Because even based on, what happened, what things that have happened yesterday, I was at the Department of Healthcare Services Substance Use Treatment Conference a few weeks ago. We have the tools. We know how to do it. There's research out there about what's effective. We know harm reduction works. We know that access to substance use treatment works. We know that having services be free and accessible works. And we're not doing it. So it starts to bring up this question of why. And usually for me, the models that I kind of think of this through is through a model thinking about industrial complexes. What are the systems that are putting us in this place? And so I have the question of, what is an industrial complex? And just to give you a little background on this, an industrial complex is a relationship. It's a business relationship that's fueled by a lot of shared interests, usually the core of which is making money, which is we live in a capitalist society. We live in a society where you have to make money in order to survive. We all have bills to pay. We all have like people to take care of, including ourselves. And just because we don't like it doesn't mean we get to disengage from the system. But what an industrial complex functions to do is it blurs these lines of business, politics, and social systems. And it puts it in a position where people continue to make money when you're not solving the problem. And just to kind of go back to California Bridge, one of the main reasons that I joined California Bridge is, you saw that map that we put up there. By 2025, we want to have access, we want 24/7 access to high quality care for people who use drugs in every emergency department in the state. Specific, measurable, we know how we're going to get there. It is time oriented, and that is how we function. And the truth of the matter is, that is not how all of our organizations function. That is not how our state functions. And so really starting to dig in, and we have a few different ways it shows up. And if you're interested in like digging into this more with me, I would love to like hop on a call and like talk more about how all these look and kind of start breaking down the way that you and your organizations might be playing roles in different parts of this. But you might have heard something like the medical industrial complex, or the prison industrial complex, or the nonprofit industrial complex, which are all these systems in which, even though you might have all these people who are really well-meaning, people who really want to make change and do things better, who are trying to influence these social places and make them better for people, when we do that without being really critical of all of the interconnections that are happening, all the relationships that we hold as organizations and as people, then what can happen is we get caught in this circle. And I think the reason that I really want to bring this up is because I feel like a lot of people in these fields are getting burned out. We feel like you're pushing on a brick wall, and you're like, I want to help this client, I want to help this patient, I want to change this system. But every time you come up to it, people are maybe around you are saying, yep, we want to do this too, we want to change this too, we want to do this. But then you start pushing and it doesn't go anywhere, because a lot of times people don't want it to go anywhere. And so if we aren't having those conversations in a much broader and bigger way, we don't actually get to start to break down those walls that are trapping us in the system that is currently existing. And so when I first read the name of this conference, like we're talking about advancing access to substance use treatment. Sometimes advancing means you got to break something down, you got to switch something up, you have to do something different. And so when we think about something like the medical industrial complex specifically, sometimes it's about breaking down what we're doing differently in terms of how we are approaching it. So one thing that we usually talk about in harm reduction world is the concept of pathologizing and patronizing people who use drugs. So pathologizing, you might have heard that term before, coming from like pathology, which is like talking about illness and sickness. And so a lot of times we can get to a place of this person is sick, and because they're sick, they don't know what's best for them. And therefore, it is my responsibility as a provider to tell them what is best for them. And along with that, we think about patronizing. Patron comes from that word for like father. And so when we are patronizing people, we're also saying they don't know what's best for them. You talk about like a kid, like that when you patronize children and you say, you are a little kid and you don't know anything. And therefore, it is my responsibility to tell you when to wake up, when to eat, what to eat, how to eat, where to go, where to show up, and all those things. And it is my responsibility, in a sense, even to raise you and to put up boundaries and tell all these things, when really, we are working with full-grown humans. We are working with mostly adults. There might be some youth folks in this room, but even when I think about doing youth work, any youth that is involved in the services that we are doing is a youth that has autonomy, that has sovereignty, and knows that they have choices. And so if we aren't engaging people in a way that recognizes that you are the expert in your own experiences, and nothing that I can really tell is going to change that. And I think I think that this shows up in a few different ways. So for example, this next point, which is like promoting academia over personal experiences or cultural perspectives, where we think about, we have this research and we've read all these papers and we've done all these things, and therefore this is statistically what is best for you, but doesn't always recognize it. So I think one place that this always shows up for me is around meth. Meth is, I worked on a lot of like crystal meth related projects my first few years in harm reduction. And the biggest thing that I kind of got out of that is meth good for you? That's a complicated question. I don't know. I think it's not probably very good for your heart. I think if you're injecting, there's a lot of risk that comes from that. I think it's not necessarily good for your lungs if you're smoking it either. But one of the most common stories that I would hear about meth when I was working in San Francisco was people saying, I sleep on the streets, and nighttime is a very, very dangerous time to be on the streets. And so if I were to fall asleep, that's going to put me at risk of being robbed, of being assaulted, of even just like people coming around and just like messing with you. And so people feel, and even on top of that, people are still working and making money. People who do sex work, people are hustling at night. They're doing all different types of stuff. And meth allows them to stay awake and do that and keep themselves safe. And if I, as a provider, were to come to that and say, meth is bad for you, stop it. And that person was like, okay, cool, I'll do that. And then that night, they fell asleep on the streets and got assaulted. Are they healthier? Are they better? And I think the most important part is that's actually not our responsibility to hold. We actually, that going back to that patronizing, it's not my job to be your parent. It's not my job to tell you what to do. It's my job to give you resources so you can make choices that work for you. And then also kind of connecting it back to talking about equity, it presents race as a determinant. And this is a little bit more of a conversation that I've been hearing more and more about, moving away from the concept of the social determinants of health. I would usually reframe that as the health consequences of society, and what happens when we build a society where certain people have less access to different things. That is actually how it comes out and how it impacts people's health. Health is an outcome. It is something that is the culmination of all of our lives. It is related to what factories were near you when you were growing up, what highways are near you throughout your life.
Yeah, what's
For
your
after the-
sustainability related to sons?
Yeah. So that's something that we're like in the process of really working out right now. So there's a few things that have been coming down the pipe. You might have heard of the community health worker benefit. That is one thing that we're currently working on, which is figuring out how we can actually have hospitals and other programs charge Medi-Cal for navigator time. That's something that like just came down the last couple months, and we're doing some pilot work around it right now. And there's like lots of other things that we've been thinking about. What does it look like to put this into a budget? A lot of it for us has been doing actually proof of concept work. So actually proving to hospitals that it is more financially beneficial for them to have this person supporting different types of patients than it is to not have them and to just like kind of push them to the side. And so there's like lots of little things. And I would, if you're interested in like really talking more about this, we could absolutely like connect you to our team. And we have like lots of little ideas that you can kind of start pushing on because that is huge for us. Like we said, like by 2025, we have this goal. We are trying to like wind up this toy and let it go. So that is like a huge piece of what we're kind of thinking about. And, you know, we've kind of played with a lot of things over the years, like SBIRT, like screening, brief intervention, and referral treatment, all these different things. Nothing has really quite stuck yet. So if you have ideas, if you have like things that you've worked on around sustainability, you would actually love to hear that.
I would just add that beyond just the business model, the financial, the benefits of having decreasing hospital length of stay, right? You know, basically when you treat people appropriately, when you're actually treating the underlying issue, the major thing that's driving these visits to the ER again and again and again, surprise, surprise, you have less ER visits you have less unnecessary workups. And there's lots of different ways that this program can be, show its benefit beyond. And so the idea is that these are Kickstarter, these initial rounds of funding are to just make it really easy, make it turnkey. You just have to just accept it. We'll even have a staffing agency, set up the hiring. We'll make everything very easy to have a substance use navigator there for a year. And they are going to prove their worth, like in every way you can imagine. The staff is going to demand that this one position out of this hospital that employs thousands of people, that this one position is a linchpin to so much care that's happening and is really helping everything go forward in the emergency department and in your hospital system. So we've just seen that again and again where hospitals have come up with their own fundings. They have a foundation that's attached to the hospital that starts to hire the, you know, so but we're also figuring out different metrics too, where Medicare will pay, where these activities will be reimbursed. So that just the straight business model part of it will be sustainable as well.
Yeah. Awesome. For people who are on Zoom, we were having a little chat about sustainability, but now we're back. So let's go ahead and just keep on pushing. So this, I can kind of just keep on pushing from this. So thinking about races, like switching up the way we think about race as a determinant. And then last, like the way that we structure our medical system really like reduces access, and it drives people to like spend money, to spend resources, to like not really be able to fully engage in care because we have these systems that don't truly encapsulate all the different abilities that people have. And so we have these systems that are really hard for people who are disabled, for people who are sick, for people with substance use disorder, and it actually does not give them a space to learn and thrive. And so when we think about bringing racial equity and harm reduction together, these are really the big pieces. This is really what it looks like. The reason that I talk about these things together, and I've actually never really been able to do my harm reduction work outside of an equity framework because it doesn't make sense. Because both of these things, what they really function to do is they necessitate a change of heart and mind. We have all these things that we have learned about people throughout our lives. Like I tell this story sometimes. I feel like I talk about my mom a lot because she does a lot of equity work as well. And so we have a lot of these conversations, but I even remember when I was a like 4 or 5-year-old walking around Indianapolis with my mom, and there was a homeless person, and my mom turned to me and said, "Yep, you see that person? That's what happens if you don't do your homework." And it's really complicated. And I'm sure every single person in this room can talk about a person who they know who is unhoused, or a person who uses drugs, who did all their homework, like I know people who have their PhD who have high level degrees, who are extremely proficient. But what we also know is that substance use is very complicated, that people's backgrounds, that people's histories, the things that they've gone through really impact them. And I live in Oakland, California, and I know just like anybody else, you are nothing but you are not a real bad week away from sitting right next to them on the street. We all are. That's just the system. That's the thing that's been created. And so it really necessitates that we change the way we feel about this work and the way that we think about it. And from an equity perspective, what that means is thinking about what are we really doing to drive care, to drive the fact that every single person who walks in this room has access to what they need. And harm reduction is about really thinking about what are all of the things that I could offer them and not being shoehorned in control or in power or anything like that. It also promotes us changing our policies and practices, because the way that we're doing things and the rules that currently exist have been created in this system that is not meant to benefit these people, these people who are coming into our services. And so we really have to think about the policies that we're breaking down. One of the things, recently we just actually launched, we have an equity webpage on our California Bridge website that you can find that kind of collates a bunch of resources that we've created and gathered, as well as kind of outlines a bit of our equity journey. Also, I'll be doing a workshop talking about this right after this, so we'll do a little plug for that at the end. But one of the big things that came up was some work that actually happened at Highland Hospital, as well as a few other places, of thinking about the relationship of police in the emergency department. What are the rights of police in the emergency department? What are the rights of patients in regards to police in the emergency department? How are you as a hospital prioritizing your patients? And there's 3 stories that come up all the time of arresting officers or people who are in custody, or of police getting in the way of medical treatment, of police dictating medical treatment, of people police refusing to leave the room, and people don't want to actually share information that their care provider needs to know in order to provide them high quality services. So you have all of these things. And so that's just like one piece of it. And when we kind of combine that with the fact that we know that people of color, we know that Black people specifically are more criminalized around substance use than any other group, when we recognize that and how that connects together, it really makes us think about, if we're going to do equity work, if we are going to change the way that we relate to this group of people, we actually have to kind of step back and say, what are all these little things that are the reasons that people actually aren't able to engage with us? The reasons people aren't coming to the emergency department, the reasons that they're coming, getting what they need, and then running out as soon as possible. All those things. I think that that it should be a safe place for people. It should be a place where you can take a deep breath and really be able to get the care you need and be stable when you leave. You should not be running out there, tying your shoe and hopping on one foot. You should be able to fully get together and walk out and feel confident that you have next steps for your care. And if people aren't actually getting set up to do that, then we're not doing our full job. And then both these concepts center those with lived experience as experts. And really thinking, and I said this at the DHCS conference as well, is it should not be a radical concept that people who use drugs should be the people working in substance use treatment. Some of us might have our own experience with drug use, whether that is chaotic or recreational, or our families, or all these different types of things. And we also have to think about, how are we really centering the people who are coming into our space? Are there mechanisms for feedback? Does that feedback actually change the way that we provide services? When somebody comes in and says, I walk in here and you make all the people who use drugs sit in this one corner and everybody else is in another corner, and then you come out and interview us and we have to tell you about all of our drug use in the lobby, and that's really uncomfortable. You could either take that and say, well, we're really overstaffed, we're really understaffed, we really have a lot of work to do, so that's just going to keep happening. Or you can say, wow, that's really uncomfortable. What is the creative option? What are the creative alternatives? Let's think about it as if it's any other problem. But when you're centering people, when it's because if the leader of your program had a feedback for you and said, this isn't acceptable, you change very quickly. You'd figure it out because that's your paycheck. But when it's our people who we're serving, we don't always move quite as quickly. And I think even more so when it's people who people think of as undesirable patients, as flaky patients, as people who are bad people even. We don't always do that. So there's really just requires this switch. So yeah, so I want to kind of just make sure that we're pushing on. So just some basic foundations of equity. And if you're interested in this, like I said, I'll talk more about this in the workshop after this. But really thinking about how the world that we exist in is really steeped in racism. However since, colonialism started in the US back in 1492, where you had white Europeans coming over and over centuries committing genocide of Native American peoples. When you think about the transatlantic slave trade, where slavery was literally the thing that built America, where you have all of these different ways that borders have been pushed and borders have crossed people, especially that's the big thing on this side of the country. When you have actually the first ever local drug law in the country was passed in San Francisco, California, which was a law that banned the smoking of opium, which is a law that specifically targeted Chinese immigrants in the late 1800s. All of those things are really the foundations that US was built in, and the systems that we're operating in were built within. And so if we don't fully recognize all of that, how are we supposed to actually start to push back on it? And more importantly, we have been socialized not to talk about it. And you might be sitting in this room right now, and as I'm saying this, you feel your pulse start to go up a little bit, you get a little hot, you're really nervous, you don't know if you're gonna say the wrong thing, and I'm gonna cancel you, I'm not. But because we don't actually have skills in talking about it, and we don't have practices in talking about it, it's really hard for us to actually move these things forward. And then also, it brings up a lot of, like I said, it brings up like a lot of these complex emotions: guilt, shame, anger, resentment, defensiveness, denial, like all these things that are very, very human. They're connected to our somatic body. They're connected to our brain, how we kind of move within all of these systems, move within our world. And it really doing this work really requires us to step back and to take a deep breath sometimes, to dislocate. I think one of the things that I tell people, especially who work in certain service programs and now hospitals, now that I do that work as well, is you can't take anything personally. People come in, they look at you, you are just the amalgamation of every service provider that they have seen in their life. You are not some special, they're not like, screw you specifically. They're like, you are a person in a role that has maybe caused a lot of harm. And so being able to step back from that and kind of manage our personal feelings and really hear what people are giving, the feedback people are giving us is important. And then on this gray side, kind of thinking about how it relates to our work, dismantling racism is everybody's work. I think the thing that I probably say the most, and me and Kara say the most at California Bridge, is we're not going to be the only ones doing equity work. We might be the ones with equity in our title. We are not going to be the only ones doing equity work. Because if we are the only ones doing equity work, what happens when I leave this role? How are we actually taking these things, like talking about sustainability? I think that that's exactly, it's all really grouped together for us. How are we making sure this money's continuing? How are we making sure that these services we're setting up can continue for a long time? And how can we make sure that these services we're setting up also are built in a way that as we replicate it and grow it and multiply it, there's a core heart about doing this work that carries throughout. And also thinking about the problem as well as the solution is in the policies we create, not just bad people. I don't really entirely subscribe to a bad person model because I think all people can change. I think that that's an important thing that I have to hold in order to do this work, is that I think all people are capable of change. But I do think it is our responsibility to create an environment that the most racist person in the world can't cause harm. How are you building a system that when you do hire a racist doctor, when you do hire a racist nurse, when you do hire a racist CEO, what are the things that they can do? What are all the checks and balances you can put in place to make sure that people are okay? What are the policies that you can put in place that create opportunities to check that person? To say, hey, you had this person come in, they were assigned to your care, they AMA'd. They left against medical advice, and you did not report it, or you did not do this step in order, or bring this person in order to try and avoid it, and that's a problem. Because that emergency department, that is the 48 hours after that are the highest risk for overdose. And if you had that person leave without giving them these resources, that is a problem. And that nurse might sit there and have an issue with it, they might have challenges with it, but when you actually build a system where it's connected to their job, they have to engage with it. They have to think about it. And I think that nurses have been, I think specifically nurses have been some of our biggest allies in this work. I've been having such a great time like working with nurses and getting to know them and like really building. And like, I think especially like hearing about Josh and the PA team at Highland, like, and all of the different like roles around, like, cause I think sometimes you get lost in the physician. But it's like, it's all these roles that really make these hospitals function and these EDs function. And there creates a lot of space for people to cause harm. So how are we actually interrupting that? And then like really thinking about as health professionals, we don't always get taught about these things. We don't get taught about these connections between injustice and oppression and health and all these pieces. And so really seeking to educate ourselves is important. This slide got a little messed up. Thinking about how we incorporate equity and harm reduction, what this says is frontline workers offer services, but leadership and back offices build them. So as a frontline worker, there's things that we can do to execute. There's ways that you can show up in your role really specially. But if you're in this room and you do background work, you are the person who builds the bureaucracy or handles the bureaucracy. You're the person who makes decisions. You are the deadliner on things. Those are the roles that really determine if we are going to have equitable and harm reduction oriented services. And so really thinking about not just like the practice side of it, but actually in the policy and in the building side of how these services are set up. We want to make sure that we're creating room for multiple directional feedback because everybody has expertise. And that's actually something that I really loved seeing in like the models we've been building with like our navigators and champions. I think that the most powerful champion navigator duos, especially in new hospitals that we see, are our navigators who are empowered and encouraged to talk back, to speak up when they see something wrong, to really shift the way that people are approaching this work and really help, and a champion that supports them or a physician that supports them and really gives them the space to say that and carries their words with the weight of being like a leader in the hospital as well. And the work can be really complex and challenging. That's probably something that y'all all understand. You probably have patients have come in and you're just like, I have no idea. Who knows where this person's supposed to be and what the next steps are. But the wins are like really worth it. And so like really being able to engage in this and recognize that we're in this for the long game. Like this system was not built in a year. This system was not built in a grant cycle. It was built over centuries. And so as we really start to transform the way that we do this work, just like really holding on to those little wins and really celebrating that. So this is like my last slide, just kind of thinking about how will you incorporate equity and harm reduction to your role. Step one can be after this session. I'm going to be leading a session about equity. I think I called it anti-racism assisted treatment is the name of it. So if you wanted to talk a little bit more about what it looks like to build anti-racist systems for substance use treatment, I'm happy to do that. And then Josh, along with one of our really wonderful colleagues, Tuesday Owen, are going to be leading a session around navigators being the keystone in all of this work. And I think that if you're interested more in the harm reduction and practice side, that'd be a great session. If you're interested more in the system side, mine would be a great session. But essentially, yeah, we're really just going to be thinking about building that out. So that's about all we have for now. I'll go ahead and like our emails are right here. Feel free to reach out. I also have some cards. I don't think Josh does, but if you get my card, then I'll connect you to him. And our emails are just like first letter, last name @californiabridge.org.